Bismillahirrahmanirrahim. My name is Dr. Meha Siddiqui, and I'm going to present today's journal club under supervision of my professor, Dr. Saira Afzal. Today, I'm going to critically appraise the article titled as Determinants of Low Measles Vaccination Coverage in Children Living in an Endemic Area According to the STROBE checklist. This is a screenshot of the STROBE checklist. Now, I will go through the highlights of the article. First comes the abstract. Measles outbreaks were recently reported in Europe due to low immunization rates. A cross-sectional study was conducted to investigate the determinants of missed vaccination in children living in southern Italy during 2016 outbreak. A standardized face-to-face questionnaire was used to record demographic data, immunization status, reasons for mixed vaccination. A total of 1,141 children with median age 86 months were enrolled. 77.8% of children were adequately vaccinated for age. 6.3% were incompletely vaccinated for age, and 15.9% did not receive any vaccine dose. Reasons for not vaccinating included fear for side effects, presence of underlying chronic conditions, skip schedule appointment, refusal for vaccination, acute illness, allergy to eggs. The presence of underlying condition was a risk factor for adequate immunization. Conclusion was that they reported inadequate measles immunization rate in southern Italy with lowest rates in children less than 2 years of age. And implementation strategies addressed to healthcare professionals and families should focus on the reported determinants to increase measles vaccination coverage. And here they have highlighted that what is known that measles is a viral, highly communicable disease preventable by vaccine. Measles elimination in Europe failed as demonstrated by outbreaks in several countries due to low immunization rates. And what's new about is that inadequate measles immunization rate due to false contraindications in southern Italy with lowest rates in children less than 2 years of age. The presence of underlying disease is a risk factor for inadequate immunization. Now, introduction. According to WHO, a vaccination coverage of at least 95% of local population is needed to prevent dissemination and reach measles elimination. However, despite remarkable progress in reducing measles incidence, vaccine hesitancy is becoming a major barrier to reach this goal. Measles elimination in Europe, defined as the interruption of indigenous transmission of infection for a 12-month period from all member states, was one of the WHO goals by 2015. However, this goal failed as report of 4,484 cases of measles in 30 European countries between Feb 2016 and January 2017. Romania, the UK, and Italy reported the highest number of cases with children below 5 years of age, accounting for more than 40% of patients. And identifying the reasons that induce parents and caregivers to refuse or to skip measles vaccination is of paramount importance to set up effective strategies of implementation of vaccination coverage. Primary aim of our study was to evaluate a measles immunization rate in children living in Campania region during the 2016 outbreak and to specifically investigate the determinants of missed vaccination in this setting. Now, methods. Study design and population. This cross-sectional study was carried out between November 2016 and March 2017 in 2 tertiary care university hospitals in the largest city in southern Italy. They enrolled a convenience sample of children aged greater than 15 months accessing the Department of Peds of University of Naples and the University of Campania. All families in ambulatory care, day hospital, regular hospitalization were invited to participate to the study. A standardized questionnaire was used face-to-face by 4 residents in Peds after receiving parents' consents, asking information on children demographic data, presence of underlying chronic conditions, ongoing chronic treatments, and immunization records. All families of children who were not vaccinated or delayed the second schedule of MMR vaccine were asked to report the reasons for missed vaccination. It was reported anonymously. Then they compared the coverage for measles with that for diphtheria, tetanus, pertussis, hepatitis B, polio, HIV vaccine to understand the specific determinants of missed MMR vaccine administration. In order to increase data reliability and to reduce reporting bias, only children whose families were exhibited the regional immunization record were included in the study. All data were loaded in a Microsoft Excel database. The observational study was approved by the Committee for the Evaluation of Clinical Studies and by the Ethical Committee of the University of Campania. Vaccination coverage and determinants of missed vaccination. According to the indications provided by Italian Ministry of Health, the first dose of MMR vaccination is currently recommended for children at 12 to 15 months of age, and a second dose should be administered in preschool children between 5 and 6 years. And based on these indications, they distinguish children in three categories: that is, not vaccinated children who didn't receive any dose of MMR vaccine; adequately vaccinated for age, that is, children who received one dose between 15 and 72 months of age, and two doses if aged greater than 72 months. Incompletely vaccinated for age, that is, these are the children who are aged greater than 72 months but who received only one dose of MMR vaccine. Then they analyze the barriers to vaccination and compare the reported reasons for not vaccinating with the contraindications and precautions for MMR vaccination. Then they analyze the data by dividing the population into 4 age groups to explore possible variations according to child age. Statistical analysis. Vaccination coverage was calculated as a proportion of vaccinated subjects to the total number of individuals in the categories studied. Face-to-face interview avoided missing data. Data were expressed as number in percentage or means standard deviation as appropriate. Comparison of categorical and continuous variables were performed using the chi-square test and the t-test respectively. An over-test was used to compare continuous variables. Chi-square with Fisher's correction was used to address any differences for categorical variables as needed. Data were further analyzed according to different age ranges. Univariate and multivariate analysis of variables influencing the risk of inadequate vaccination was performed using the logistic regression analysis and Cox regression model. Risk was reported as odds ratio with 95% confidence interval. Statistical analysis were performed using the SPSS software. A p-value less than 0.05 was considered statistically significant. The study was conducted according to the STROBE checklist of cross-sectional studies. Now, results. This is the flow diagram that they showed how they screened and selected patients, then enrolled and outcomes. First, families invited to the participants to the study were 1276. Then the families who refused to take part to the study were 5 in number. Then families who agreed to participate to the study were 1271. Then families not exhibiting their own children immunization records were 130. Then children enrolled in the study were 1141. And families not available to report the reasons for not vaccinating their children were 13 in number. And finally, children whose data were analyzable for determinants of missed vaccination were 1128. And children whose data were analyzable for vaccination coverage outcome were 1141 in number. Then this is the table showing characteristics of study population. That is their gender, median age, and different age groups, and their underlying chronic conditions and other factors. Then measles vaccination coverage, that is children receiving 0 dose, 1 dose, and children receiving 2 doses. Then this is the graph that is showing measles vaccination coverage in different age groups, like less than 24 months, then 25 to 72 months. And they have shown that how many of them were adequately vaccinated, then incompletely vaccinated, and not vaccinated. Now, determinants of missed vaccination. 22.2% were not appropriately vaccinated according to age. Different reasons for not vaccinating were reported by families, including fear for MMR vaccine side effects, presence of underlying chronic conditions, skip forget a scheduled appointment, overall refuse of vaccination policies, presence of concomitant acute illness and allergy to eggs. One patient was undergoing chemotherapy, and 13 children, parents refused to report the reasons for omitting vaccination. The MMR vaccination coverage in children with underlying chronic conditions was significantly lower. The presence of any underlying chronic condition was a major risk factor for inadequate measles immunization, and male children had a slightly higher risk of inadequate vaccination coverage. So this is the graph showing that reasons for not vaccinating according to the age range, and these are the different reasons like egg allergy, immunosuppressive treatment, missed appointment, acute illness, underlying chronic conditions, and fear of side effects and against vaccination. Then this is the table showing reasons for not receiving vaccination in the study population. Now discussion. According to the results, strategies to improve MMR immunization rates should address two different audiences: healthcare practitioners and families. An appropriate and updated education should be provided to physicians and other healthcare practitioners involved in vaccination policies, and in parallel, simple, unambiguous, and straightforward information should be disseminated to general population in order to improve vaccination uptake. During outbreaks, all healthcare practitioners have to offer vaccination in indicated times, check vaccination schedule of all patients, and offer catch-up vaccination to those who were not vaccinated at the appropriate time. This study has some limitation. First is that the study population included children who referred to clinical departments of peds rather than involving the overall healthy pediatric population. So in such setting, the proportion of children with severe conditions might be overrepresented in comparison to other settings and may potentially impact on the overall vaccination coverage. In order to limit the selection bias, they enrolled the large pediatric population, including children in outpatient and inpatient settings. To avoid potential reporting bias, only children exhibiting the immunization records were included in the study. In addition, they didn't investigate the role of different healthcare workers in suggesting or providing vaccination to the study population. However, based on previous data collected in the same setting, they are aware that immunization is mainly recommended by primary care pediatricians and physicians working in referral centers, with vaccination centers seeming to have little or no effect. This redundancy of role by physicians managing children, mainly those with at-risk conditions, has been identified as further barrier to vaccine uptake. In conclusion, we reported inadequate measles immunization rate in children living in southern Italy in concomitance with measles outbreak. The vaccination coverage was lower in children below 2 years of age and those with underlying chronic conditions, who are those potentially exposed to severe complications and death. Only a minority of not vaccinated children presented conditions that really contraindicate vaccination. The fear of MMR-related adverse events, the inappropriate interpretation of chronic diseases, and suspected allergies as potential contraindications were the main barriers to MMR vaccine uptake. Strategies to implement MMR vaccination should focus on these determinants of missed vaccination to increase measles immunization rate. Compliance with ethical standards, conflict of interest. The authors declare that they have no conflict of interest. Ethical approval. This article does not contain any studies with human participants or animals performed by any of the authors. Informed consent. Informed consent was obtained from all individual participants included in the study. Now, critically appraising the article using the STROBE checklist. First point is that indicate the study design with a commonly used term in the title or the abstract. A cross-sectional study design was mentioned in the abstract. Second is provide in the abstract informative balanced summary of what was done and what was found. Abstract provides a balanced informative summary of what was known and what was found. Background rationale explain the scientific background and rationale for investigation being reported. Background is well explained and rationale too is well elaborated. Objective states specific objectives, including any pre-specified hypothesis. Yes, objectives are clearly defined. Then study design, present key elements of study design early in the paper. It's presented. Describe setting, location, relevant dates, including periods of recruitment, exposure, follow-up, and data collection. Yes, setting, collection, locations, relevant dates, and about data collection, they all are mentioned. Participants, give the eligibility criteria and the sources and methods of selection of participants. Exclusion criteria is not mentioned. However, participants collected through convenience sampling. Clearly define all outcomes, exposure predictors, potential confounders, and effect modifiers. Give diagnostic criteria if applicable. Outcome variables are defined. However, predictors, potential confounders, and effect modifiers are not mentioned. Data sources measurement for each variable of interest. Give sources of data and details of methods of assessment. Yes, sources of data are mentioned as they have told that it is a through face-to-face interview and their immunization records. However, no details on methods of assessment is given as it was not needed in this study. Bias, report any efforts to address potential sources of bias. Reporting bias are well addressed. Study size, explain how the study size was arrived at. It is not explained how the study size is arrived. Quantitative variables, explain how quantitative variables were handled in the analysis. T-test was used for comparison of continuous variables and over-test was used for more than two groups. Statistical methods describe all statistical methods, including those used to control for confounding. It is well mentioned. Describe any methods used to examine subgroups and interactions not mentioned. Explain how missing data were addressed. Missed data was avoided using face-to-face interview. If applicable, describe analytical methods taking account of sampling strategy. It is not used. Participants report number of individuals at each stage of study. For example, numbers potentially eligible, examined for eligibility, confirmed eligible, included in the study, completing follow-up and analyzed. It is addressed as given to the flow diagram. Descriptive data give characteristics of study, participant, information exposure, and potential confounders. Characteristics of study participant, for example, demographic, clinical, and social are given, but no information on exposure and potential confounders is given. Indicate number of participants with missing data for each variable of interest. It is mentioned that for 13 children, patient refused to report the reasons for omitting vaccination. Outcome data, report number of outcome events or summary measures. It is well mentioned. Then moving on to results, give unadjusted estimates, applicable confounder adjusted estimates in their precision. Make clear which confounders were adjusted for and why they were included. It is not mentioned because they haven't talked about confounders. Consider use of a flow diagram. It is given. Report other analysis done like subgroup analysis and sensitivity analysis. It is not mentioned. Key results, summarize key results with reference to study objectives. It is well summarized. Discuss limitations of the study, taking into account sources of potential bias or impression. Discuss both direction and magnitude of any potential bias. Limitations with potential bias are well mentioned and how they were addressed. Interpretation. Give a cautious overall interpretation of results considering the objectives, limitations, multiplicity of analysis, results from similar studies, and other relevant evidence. It all is given and discussed. Generalizability. Discuss the generalizability, external validity of the study results. It is discussed. Funding. Give the source of funding and the role of funders for the study, present study, and if applicable for original study on which present article is based. They haven't mentioned about funding. Now, strengths. Article was well written, concise, grammatically correct. Title is clear, accurate, and unambiguous. Abstract offers a clear overall overview of the study, including the research problems, samples, methodology, finding, and recommendations. Introduction provides sufficient background information along with rationale of the study. Target population clearly identified, sampling technique mentioned, ethical considerations were followed, operational definitions were given, appropriate variables were chosen for answering the question. Flow diagram was given to show the final selection of participants in the study. Appropriate statistical tests for categorical and continuous variables were used. Tables and graphs were presented in clear fashion complementing the text. Findings were linked back to the literature review along with limitations and way forward in discussion. Weaknesses, sample size was not calculated, exclusion criteria was not well mentioned in methodology, confounding test to control confounders were not mentioned, and funding was not addressed. So this is the YouTube link of this presentation, and thank you.
Thank you so much, Dr. Meha. It's a very nice presentation. And all the slides were very clear and you described the article very well. A few points I would like to add in your appraisal would be that regarding starting from the title. Although the title is mentioned, they somehow try to address the objective and the purpose of the study with the population, but I think it would have been more accurate if they have added they have defined the age they are taking, age range, the geographic area, if they would have mentioned, and which type of determinant they are addressing, right? It would have made it more accurate, innovative, and relevant to the study. Regarding the abstract, in the abstract, there was a bit of the background, but a no specific objective statement was mentioned in the abstract. So that was missing in that. And seconding your opinion, there was no exclusion criteria that was mentioned in the abstract. However, in the methodology section of the abstract, it was explained very well, results were given, conclusion and ethical approval was also mentioned. So almost all the points were covered. So in the abstract, there were few points that were missing. In the introduction, the sufficient scientific background was given, primary aim was also mentioned, merged with the rationale. So it was overall a good introduction. In methodology, the key elements of the study design, like the type of the study, the participants, the sampling technique, location, and setting, were given. What questionnaire used, what variables and outcomes, and also the reporting bias. But the sample size calculation, as you have already mentioned, was not there, and with the absence of an inclusion and a strong inclusion and an exclusion criteria, so it somehow uh, introduce some ambiguities in that sampling selection. How the total number of participants were selected, as you have shown, was given in the figure. Operational definitions were good, and overall, the other points were fulfilling the criteria of the STROBE checklist. As far as the results are concerned, the total participants, the dropouts, with the results representation in terms of prevalence and standard deviation were given. Also, the p-values were mentioned. But as you've already told, that the control of confounders and missing data was not mentioned, and no there was a bit of analysis where they divided the whole of the data in age groups and then did the analysis. So we can say that there was a division of the data in groups, but no sensitivity analysis or mention of that type of analysis or the control of confounders were there. So results were good and clearly defined and graphically represented, and tables were very clear. Discussion part was good, limitations were there, interpretation data, and since we have not mentioned any kind of hypothesis, so considering the generalizability of the result was not applicable for this study. And since it's not some kind of an interventional study or some, so funding not applicable from my point. So summarizing my points, that the title was not as accurate and more defined as could have been by adding those points. So abstract, there was a no clear objective statement mentioned and no exclusion criteria. Sample size calculation was missing in the methodology. Control of confounders and missing data, how they handled it, was not there. And these are all the points that are from my side. If I would like other participants to add more points from their side as well. Thank you.
Assalamu alaikum. Meha, very good critical appraisal. Dr. Amber already has described it very well. Few points which I try to explain. These studies threats to many validity. For example, there is no sampling technique, random sampling technique, inappropriate study design, not mentioning of sample size. There's many internal validity threats. If the study is not internally valid, then how it come externally valid? Therefore, there's many problems regarding the internal and external validity. Second point is that not distinction between prevalent and incidence cases. As the case control study more importantly determine the prevalent case and not consider the incidence case. So a child which died before included in the study from measles is not included. This how the study address the prevalent incidence cases problem is not mentioned in the study. And then the challenge is effect modifier, confounders, and biases. There are many effect modifier, confounder, and biases which I have prepared a list regarding to the any vaccination study which you are performing. If you are performing any vaccination coverage of any disease in any area, you should stratify data according to especially in children, according to maternal factor, childhood factor, household factor, and socio-cultural factors, which is given by WHO. Because every level of factors, for example, maternal age, education, ANC visits, vaccination, prenatal attitude, beliefs are not given in the same way. Household income, family size, residence is not mentioned. All are these four stratification of factors, whether it is household, maternal, child, and the socio-cultural factors are, should be, or they can be confounders, which is a spurious association between cause and effect. They can be fact modifier, which is actually the association between effect and cause that vary according to the third level of factors, and they can be also a source of bias. And importantly, I noticed that in this study, the bias is not only the selection bias, but there is a detection bias, information bias, and recall bias. How they address four important factors: internal validity, external validity, biases, confounders, effect modifiers, according to four level of strata, are not mentioned. I think these 5 points I should recommend should be addressed. If they try to address in the analysis phase, then they mentioned that they apply the regression analysis. But then where is the weightage model? Where is adjustment in the analysis phase? These are few points they should try to address. Therefore, this study is not internally valid. I think so, not externally valid, because not appropriate study design, mentioning sampling technique, inappropriate sample size is not mentioned, and few points. Thank you.
Thank you so much, Dr.
Assalamu alaikum. Thank you so much for the valuable feedback, Dr. May. It was a nice presentation, and Dr. Amber and Dr. Hansa has elaborated it so well with all the points I think have been mentioned. So the very few comments from my side, basically, the study design was missing the title, then in the objectives were not clearly mentioned, and you can say otherwise the flowcharts and diagrams were there and well written background, and the remaining points which are very important are being told by Dr. Khalsa and Dr. Amber. Thank you so much.
Thank you so much, Dr. Khansa, Dr. Sadia, for your feedback. Any other comment from any other participant? And please, Dr. Meha, add a few more points regarding, as they have been mentioned by Dr. Khansa and Dr. Sadia and myself.
Okay.
And yes, and the point of that Dr. Khansa has said are truly valid, and the study would have increased its generalizability and validity of the results if the authors have added these points. So thank you so much from my side, and from everybody. If there are no comments, we can finish the meeting.
Thank you so much, Dr. Amber, Dr. Khansa, Dr. Sadia, for your feedbacks.
Thank you. Allah
Allah
Hafiz.
Hafiz.